Very good evening, everyone, and welcome to the sixth webinar of a series of webinars hosted by Faculty of Dental Sciences, University of Peradeniya, Sri Lanka. I'm Dr. Sumudu Medawela from Faculty of Dental Sciences. Today, we have an eminent oral pathologist in the country with us, Professor Primali Jayasooriya. Professor Primali Jayasooriya is currently attached to the Department of Oral Pathology, Faculty of Dental Sciences, University of Peradeniya, Sri Lanka. Her academic career spans for more than 2.5 decades. She is a graduate of Faculty of Dental Sciences, University of Peradeniya, and she earned her first postgraduate qualification, PhD, from Tokyo Medical and Dental University, Japan. Later, she extended her academic aura with MD in Oral Pathology, University of Colombo, Sri Lanka. She currently works in the capacity of the head of the department and professor in Oral Pathology. She made her valuable contribution to numerous academic forums nationally and internationally, and she received multiple awards, including multiple presidential awards and National Research Council Merit Awards for scientific publications. Her research interest is on molecular pathogenesis of oral squamous cell carcinoma and odontogenic tumors. Also, she has co-authored more than 50 international full paper publications. With that introduction, let me invite Professor Primali Jayasooriya to deliver her presentation. She will be talking to us on a pathological perspective on the management of odontogenic lesions. Over to you, madam. Until the things get prepared, today Dr. Udari Abeyasinghe is assisting me for this webinar.
Thank you, Dr. Sumudu, for that kind introduction. Good evening, everyone. Today's topic is pathological basis of management of odontogenic lesions. 2017 WHO classification categorizes ameloblastomas into 4 different subtypes. These are the conventional, unicystic, extraosseous or peripheral, and metastasizing ameloblastoma. Today, I decided to select ameloblastoma for the discussion, mainly because the management strategies of ameloblastoma depends on the histopathological diagnosis. OKC was selected because it is a lesion with a high rate of recurrence. First, let's look at the background information. Origin-wise, both lesions arise from the remnants of the tooth-forming apparatus. OKCs that arise posterior to the third molar region may arise from the oral epithelium, mainly because the dental lamina does not extend beyond the third molar tooth. Intraosseous ameloblastomas, on the other hand, may arise from any type of remnants of the odontogenic apparatus, while the peripheral ameloblastomas arise from the oral epithelium. Both lesions are more common in young adults and adults, but they are not all that common at extremes of age. Both lesions show a predilection to the posterior mandible, with radiologically both presenting as uni or multilocular radiolucency. There's one exception to this presentation, and that is desmoplastic ameloblastoma, which shows a predilection to the anterior region of the jaws and present as a mixed radiodense lesion mimicking fibroosseous lesion. Recurrences are common, particularly if conservatively managed. Long-standing lesions may give rise to malignancies, OKC giving rise to intraosseous carcinomas and ameloblastomas giving rise to ameloblastic carcinoma or metastasizing ameloblastoma. Both lesions may present with mutations that can be translated to gene therapy. OKC present with a mutation in the catch tumor suppressor gene, while most subtypes of ameloblastomas may present with a mutation known as BRAF V600E, which is the same mutation that is found in melanomas. Approximately 5% of the OKCs are multiple and associated with nevoid basal cell carcinoma syndrome. Regarding the clinical visibility, OKCs grow in an antero-posterior direction, so clinically visible lesions may not appear till the lesion has reached a large size. This can be a disadvantage during surgical intervention. On the other hand, ameloblastomas grows in all directions, and the presence of both lingual and buccal bone expansion can be a clue to diagnose ameloblastoma. Gross presentation-wise, OKCs are purely cystic lesions, while ameloblastomas may present as cystic, solid, or multicystic, depending on the histopathological subtype. Now, if you see a patient with a multilocular radiolucency, which type of biopsy should you perform? First of all, before we decide on the type of biopsy, you should consider the radiological differential diagnosis for a multilocular radiolucency. These would include OKCs, conventional ameloblastomas, even lesions like central giant cell granuloma, brown tumor, or myxoma, which require different management strategies. Therefore, an incisional biopsy is extremely important prior to deciding on the management. On the other hand, if a patient presents with a small unilocular radiolucency, you can straight away go for an excisional biopsy, provided conventional ameloblastoma is not included in your radiological differential diagnosis. Can you identify these specimens? The first picture shows a cystic lesion with white material inside it. This is mainly keratin. So this can be a OKC or an orthokeratinized odontogenic cyst. If you want to differentiate the two lesions, histopathological analysis is important. Without the histopathology, it is not possible to differentiate a OKC from the orthokeratinized odontogenic cyst. Second picture shows a lesion with solid areas and also cystic areas. So this can be a conventional ameloblast. How do OKCs grow? Now you must be wondering why I am talking about the growth mechanisms of OKCs, because today's topic is mainly pathological basis of management of odontogenic lesions. This is mainly because if you know the mechanisms of growth, then it is very easy to understand the pathological basis of management. So when we consider the mechanisms of growth, firstly, the lesion may grow due to intraluminal hyperosmolality. That means the osmotic pressure inside the cyst is high compared to the outside environment. So the fluid will come into the lesion. When the fluid comes into the lesion, the lesion can grow. This type of growth will occur equally in all directions. Second mechanism is the active epithelial proliferation. With reference to active epithelial proliferation, another term could be intrinsic growth potential of the cyst epithelium. This is supported by the presence of suprabasal mitosis as well as basal mitosis in the epithelial lining of the cyst. By this method, the cyst only grows in one direction, that is, anteroposteriorly into the marrow space. As the cyst is surrounded by bone, resorption of bone also has to take place in order for the cyst to grow. So the resorption of bone takes place by the secretion of interleukins. These interleukins are secreted by the keratinocytes of the cyst epithelium, and the interleukins can stimulate the RANK-L pathway and stimulate osteoclast. Also, interleukins can stimulate the keratinocyte growth factor and tumor necrosis factor, which in turn will increase the secretion of prostaglandins and parathyroid related proteins, which will in turn resorb the bone. I think all of you all are aware of the histopathology of the OKC. Generally, OKC presents as a cystic lesion lined by a parakeratinoid stratified epithelium with basal cell palisade. Sometimes in the capsule, you may also see what is known as daughter cyst or satellite. Now, why do OKCs recur? There are several reasons, and the first reason is if you look at the epithelial connective tissue interface, you see a flat epithelial connective tissue interface in the OKC. So, when the surgeon tries to remove the lesion, the epithelium may get easily separated from the fibrous tissue capsule. If the surgeon leaves pieces of the epithelial lining inside the bone, it can give rise to new lesions. Another feature would be if the surgeon leaves pieces of the fibrous tissue with satellite cyst, again it can give rise to new lesions. The second point is that the OKC grows in an antero-posterior direction into the marrow spaces. Once a lesion grows into the marrow spaces, it is very difficult to remove the whole lesion without breaking. So, during surgery, if the surgeon leaves pieces of epithelium or satellite cyst behind, those can give rise to recurrence. Now, if a patient presents with multiple OKCs, it is essential to exclude Golling-Girl syndrome or knee-wide basal cell carcinoma syndrome. There are 6 major criteria and 5 minor criteria that you have to consider when diagnosing knee-wide basal cell carcinoma syndrome. And out of these, if you can identify 2 major criteria in your patient or 1 major criterion and 2 minor criteria, then you can diagnose these patients to have knee-wide basal cell carcinoma. This slide shows several pictures of features of NBCCS. First radiograph shows the calcification of the falx periphery. In the second radiograph, you can see multiple cystic lesions. If you take biopsies, these will be OKCs. And in the third picture, you can see some basal cell nevi, and one of it is changing into a basal cell carcinoma. With reference to the basal cell carcinomas that occur in nevoid basal cell carcinoma syndrome, there's one important point that you have to remember, and this point is generally in nevoid basal cell carcinoma syndrome, the basal cell carcinomas occur in areas that are not exposed to direct sunlight. In contrast, if you consider sporadic basal cell carcinomas, they occur in areas that are exposed to direct sunlight, like the face. Now, if you ask me whether there are any diagnostic features to differentiate cases of syndromic patients from non-syndromic patients, the answer that I can give you is no. But there are clues to suggest cases of syndromic patients. The best clue is the presence of multiple cases. In addition, cases that occur at a younger age, maxillary lesions, and anteriorly located lesions are more commonly seen in syndromic patients compared to non-syndromic patients. Histopathologically, in syndromic patients, you may see multiple dermatocysts and also epithelial budding and solid epithelial items. There's one important thing about the nevoid basal cell carcinoma syndrome, and that is dental surgeons and also OMF surgeons can contribute immensely for the diagnosis of this syndrome, mainly because the cases occur at an earlier stage compared to other features like the basal cell carcinoma. Now, with reference to the treatment modalities, as I am not a clinician, I prepared this table using two systematic reviews. So, regarding the treatment modalities of cases, majority should be treated conservatively. Where with reference to the conservative treatment modalities, marsupialization and decompression can be applied if the lesions are very large and these lesions are situated close to vital structures. Radical treatment should be reserved only for lesions that show multiple recurrence. Now, what is the difference between decompression and marsupialization? In both techniques, a small window is opened. You remove a small part of the cyst and create an opening into the oral epithelium. In the case of decompression, this window or the opening is maintained by a decompression tube. In marsupialization, the opening is maintained by suturing the edges of the cyst to the oral mucosa. So in both methods, mainly what happens is the pressure or the osmotic pressure that results in the growth of the lesion is removed. So, with time, the lesion will become smaller. Now, if you look at the epithelial lining of a lesion that has undergone marsupialization or decompression, you will not see the typical epithelial lining that you would observe in a case. Instead, several changes can be seen, and one of these changes are that there's de-differentiation of the epithelium. De-differentiation means the changes occur so that the cyst epithelium becomes similar to the oral epithelium. So if you look at it under the microscope, parakeratoid stratified squamous epithelium of the epithelial lining in an original OKC will change to an orthokeratinoid stratified squamous epithelium similar to the oral mucosal epithelium. In addition, after decompression or marsupialization, the thickness of the epithelium will also change and the thickness will increase. August et al. Have also shown that certain changes may occur in the cytokeratin profile. One change that can occur is that in a primary OKC, they express cytokeratin 10. But with decompression or marsupialization, with the de-differentiation of the epithelium, cytokeratin 10 expression gets removed and you don't see the expression of cytokeratin. Now, but still, there's one important thing that you have to remember, and that is, though the cyst lining per se show changes, according to August et al., the cytokeratin expression, even after marsupialization in a satellite cyst, will remain the same. That means, even after marsupialization, the satellite cyst will retain the proliferative capacity of the epithelium. Another change that we may see is in a primary OKC, you will see a lot of proliferative activity demonstrated by markers such as I67. But after the differentiation, the proliferative activity gets reduced. But even after decompression, if there are satellite cysts, they will retain the proliferative activity. So that means after the differentiation, once the lesion becomes very small, you have to enucleate the lesion. If you don't enucleate the lesion, the satellite cysts that remain in the capsule may give rise to new lesions. There's another adjuvant method that can be used in the management of OKC, and that is liquid nitrogen therapy. Now, when you consider the process of tissue damage, with cryotherapy, mainly the organic tissue is destroyed. So that means the daughter cyst or epithelial remnants will be destroyed once you apply cryotherapy. The cells are destroyed by the direct damage due to accumulation of intra and extracellular ice crystals. There's one disadvantage in using liquid nitrogen therapy, and that is when you apply the cryotherapy, the pathology is not visible or become invisible. So if you want to keep the pathology visible, to remove it, it is better to apply a dye. Example would be 1% methylene blue dye. So this dye will be taken up by the nuclei of the epithelial cell. So once you apply the dye, and after you apply the liquid nitrogen therapy, still if blue areas remain, that means the epithelial cells of proliferating epithelial cells of the cyst lining is remaining in the surgical site. So by continuous cycles, you can apply the dye and then you can see, again apply the liquid nitrogen cryotherapy, and then you can try to remove all the epithelial cells that remain in the lesion by periodically applying methylene blue. The function of the methylene blue is that the nuclei, proliferating nuclei of the epithelial cells that remain in the lesion will be taken up by this dye. What are the advantages? There are several advantages also. As I said before, liquid nitrogen therapy only destroys the organic matter. So the bone matrix itself is left behind and it can act as a scaffold for new bone formation. Also, after liquid nitrogen therapy, you can do a bone graft immediately and it may accelerate the healing process and it can minimize the pathological fractures as well. And also, in contrast to carnal solution, with liquid nitrogen therapy, the neural damage that occurs is reversible. So those are some of the advantages. What about the use of carnal solution for treatment of OKC? So it's a cauterizing agent that causes rapid fixation. One disadvantage of carnal solution is that chloroform that we include in the carnal solution is a carcinogenic substance. So in some countries, people are not allowed to use chloroform. So certain investigators have prepared a carnal solution, a modified carnal solution without chloroform as well. But still, there are no data regarding the successfulness of the carnal solution, modified carnal solution. Now, another disadvantage of carnal solution is that it may produce permanent neural damage. Cryotherapy does not produce permanent neural damage, but carnal solution Now, with reference to the site of application of carnal solution, if you read the literature, if that happens, it will induce a chronic inflammatory reaction and the cyst wall will become more fibrous. When the cyst wall becomes more fibrous, it can be easily removed. Secondly, you can also apply the carnal solution to the bone after enucleation. So, by this method, it will destroy the remaining epithelial fragments or the satellite cysts. Now, what are the factors that contribute to the recurrences? I looked at several articles, and one article that was published in Trainee Surgery in 2016 indicates that the overall out of 6,000 recurrences are more common in patients who have nevoid basal cell carcinoma syndrome. If the lesion presents as multilocular lesion and also depending on the treatment. Of recurrences are observed with marginal or segmental resection. But generally, as the OKC is a simple cyst of developmental origin, radical treatment is not indicated. Also, these investigators found that there's no contribution to recurrences when the gender or site of the lesion was considered. Sumudu, now can we go to the poll?
Yes, madam. I'm going to I'm going to share the first poll. The poll is on the screen, madam. We are receiving the answers, madam.
Okay. Can you show the results?
I think still the answers are piling up, madam. Can we wait for a few more seconds?
Sure.
Yes. Yeah, I'm going to end the poll. So the results are on the screen, madam.
Actually, the correct answer is the second one, an 8-year-old child presenting with an OKC at the anterior maxilla. This is mainly because if you consider the typical presentation of OKC, there are two ages in which you see a predilection. One, at one point, you may see a lot of OKCs developing in patients who are young adults, those who are in their 20s. There's another distribution where you would see it in 50-year-olds. So, but if you consider the second answer, maxilla is not a common site, and also though the OKCs occur in young adults, they are not very common in children. So that is the correct answer. Can we move on to the second piece?
Yes, I think there's a radiograph in the screen, madam. Can we share the radiograph, please? Yes. So I'm launching the question, madam. It's on the screen. We are receiving answers.
Can we see the results?
Yes, madam. Okay, I'm sharing the results, madam. Results are on the screen.
That is the correct answer, incisional biopsy, mainly because it's a very large lesion. So you have to do an incisional biopsy to arrive at a definitive diagnosis. Shall we move on to the third one, Sumudu?
Yes, madam. I'm launching the question. It's on the screen.
Can we see the results, Sumudu?
Yes, madam. Results are on the screen, madam.
Yeah, decompression is the correct answer. Next one, Sumudu.
Yeah. The last poll. It's on the screen.
Can we see the results?
Yes. The results are on the screen.
Yes, that is the correct answer, multilocular radio. There's another one.
I'm extremely sorry, madam. I think there's a technical problem, and the question is not launching. Could you please proceed with the?
Yeah. Okay. So
Yeah.
the question is,
Thank you.
You look at the radiograph, and this radiological presentation would be commonly seen in A would be unicystic ameloblastoma, B, a follicular ameloblastoma, or 3, C, a desmoplastic ameloblastoma. So here, because you see a mixed radiodense type of lesion in the anterior mandible, the answer is desmoplastic ameloblastoma. Okay, let's move on to the ameloblastoma. So if you can remember my second slide, I said that there are 4 types of ameloblastoma. The first type of ameloblastoma is the conventional ameloblastoma. Histopathologically, there are 4 types of conventional ameloblastoma. These are the follicular, plexiform, acanthomatous, granular cell, basal cell, and desmoplastic subtypes. The thing about these different histopathological subtypes are that though these can be identified as different histopathological subtypes, the management strategy for these different histopathological subtypes do not vary. So all the conventional ameloblastomas should be managed radically. This is mainly because if you look at the growth pattern of the ameloblastoma, though it's considered as a locally aggressive benign lesion, tend to invade into the surrounding bone. Also, it can erode the bone and present in the soft tissue. It can also grow in the soft tissue. So because of that, all the conventional ameloblastomas, irrespective of the histopathological diagnosis, should be managed radically. Now, if you look at the last picture, it shows a desmoplastic ameloblastoma. Now, in the 2005 classification, WHO classification, desmoplastic ameloblastoma was considered as a different subtype, mainly because it shows different clinical pathological presentation. But in the current classification, desmoplastic ameloblastoma was again considered as a subtype of conventional ameloblastoma, mainly because the management strategy of the desmoplastic ameloblastoma is similar to other conventional ameloblastomas. So, again, conventional ameloblastomas should be managed radically, irrespective of the histopathological subtype. Second type is the unicystic ameloblastoma. There are 3 types of unicystic ameloblastomas. These are the luminal, intraluminal, and mural subtypes. In the case of luminal unicystic ameloblastoma, you would see a simple cystic lesion lined by odontogenic epithelium. If you look at this odontogenic epithelium, you may see basal cells that show ameloblast-like morphology, stellate reticulum-like cells, as well as vacuolated cells. Now, if you consider the intraluminal subtype, there, in addition to the simple cystic lesion with the odontogenic epithelial line, you may see a bulge of ameloblastomatous tissue which extend into the cyst cavity. The third type is the mural type. There you will see ameloblastomatous silence in the cyst cavity. So there are 2 things that you have to remember. Now, although I said that the unicystic ameloblastomas have a characteristic epithelial lining composed of ameloblast-like cells, stellate reticulum-like cells, and vacuolated cells, this appearance is not present all over the lesion. So, if you are planning to take an incisional biopsy, it's better to take a fairly large section because In some areas, the characteristic epithelial features may not be present. And also, when we receive the biopsies, if we suspect a unicystic ameloblastoma, we may have to take serial sections to arrive at a definitive diagnosis by identifying the characteristic epithelial features. Management-wise, luminal and intraluminal unicystic ameloblastomas can be managed conservatively, while the mural unicystic ameloblastomas require radical treatment similar to a conventional ameloblastoma. This is because now I said that in the mural subtype you can see ameloblastomatous silence in the capsule. With time, it can invade into the narrow spaces and behave as a conventional ameloblastoma. So that is why the mural ameloblastoma requires radical treatment, whereas the luminal and intraluminal subtypes may require only conservative treatment. Third type is the peripheral ameloblastoma. Peripheral ameloblastoma generally presents as a small swelling in the gingiva and it can clinically mimic an epilobe. Now, regarding the histopathological subtypes that you may see in peripheral ameloblastomas, the commonest type is the basal cell type. So, if you look at the picture, you can see a tumor composed of islands of basal looking cells. But you don't see the characteristic ameloblast-like cells or even the stellate reticulum-like cells in the basal cell type of ameloblastoma. So, some of the peripheral ameloblastomas may be mistakenly diagnosed as basal cell carcinoma. This is mainly because histopathologically, majority of the peripheral ameloblastomas will show a basal cell morphology. Another thing that you have to remember about the peripheral ameloblastoma is, even if you get a report saying peripheral ameloblastoma, it is essential to take a radiograph and exclude the presence of a central lesion. Because sometimes these central lesions may erode the bone and present as a peripheral swelling or a swelling in the gingiva, mimicking a peripheral ameloblastoma. Regarding the management of peripheral ameloblastoma, simple excision of the lesion is curative. The last subtype is the metastasizing ameloblastoma. So, this is a lesion with a metastasizing potential, but even the secondary tumors produced show benign histopathological features. So, that is why, though this lesion has the ability to produce secondary lesions at distant sites, in the 2017 WHO classification, metastasizing ameloblastoma is considered as a benign odontogenic tumor. Reason being that even the metastases show benign histopathological. Management-wise, if it is a metastasizing ameloblastoma, surgical excision of the metastasis can be done if the lesion is accessible. Otherwise, you may have to do chemotherapy or radiotherapy. Now, in addition to these traditional treatment methods, there are also some novel treatment options for ameloblastomas. One method is the dredging method. In the dredging method, we can apply the dredging method for purely cystic lesions or lesions that show cystic as well as solitary. So if we consider the purely cystic lesions, they are initially deflation followed by enucleation is performed. After that, you have to start the dredging. So periodically, once in every 2 or 3 months, you have to remove the scar tissue and also some bone tissues in the. So you can periodically do the dredging technique till you get 2 consecutive biopsies without any neoplastic epithelium. So if we consider the pathological perspective, in dredging method, you remove the scar tissues. When you remove the scar tissue, if there are any persisting neoplastic cells, those are also reduced. So it reduces the possibility of recurrence. In addition, with deflation, pressure within the cystic tumors are released, and this can facilitate new bone formation. And also, with periodic osteectomy, bone morphogenic protein is released, which also facilitate new bone formation. Another treatment method would be I said that some of the ameloblastomas may present with a mutation known as BRAF V600E. It is a point mutation where the thymine nucleotide is replaced by adenine. So this gene therapy can be applied for recurrent or pediatric ameloblastoma. Generally, VRF inhibition therapy, at least 2 agents should be used. Now, unfortunately, still gene therapy is not available in Sri Lanka. So these are the take-home messages. Exclude nevoid basal cell carcinoma syndrome in OKC patients with atypical clinical pathological presentations. Concern regarding leaving parts of the proliferating cyst epithelial lining within the bone should not be a basis for excluding decompression or mass visualization in the management of OKC. Dredging and gene therapy are 2 options available to conservatively manage conventional ameloblastoma. Thank you.
Thank you very much, Madam, for that excellent presentation. Madam, we have a few questions posted from doctors who are listening this webinar. I will take the first question. Now, this is from Dr. Aishwarya Kulkarni. Please guide us where to use which biopsy.
I suppose they want to know from which side to take the incisional biopsy. So if that is the question, I think you should avoid the superficial mucosa and you should take a biopsy from the deep region of the lesion.
Okay. Udari, can we have the second question?
Madam, Dr. Yoita Prabhunath has raised 2 questions. Different ameloblastoma as just 2 different histological patterns or as 2 different biological behavior of ameloblastoma?
I think you should consider plexiform and follicular ameloblastoma as 2 different histological patterns only. They both behave in the same manner.
The second question is, can we say only follicular and plexiform ameloblastoma were the true histological entities and all other patterns were variants of these two entities?
Yes, you can say that, because generally we say that in ameloblastomas they exhibit two growth patterns. So those two growth patterns are the follicular and the plexiform patterns.
Okay, Madam, we have another question from Dr. Shifa Thakur. Ma'am, can you please explain difference between decompression and marsupialization?
Yes, so when you consider decompression, in the lesion, you will open a window so that the cyst is opened into the oral environment, and into this window, to keep it open, you will put a decompression tube. That is the decompression technique. Whereas in marsupialization, again, you will release pressure and you will open a window so that the cyst cavity is exposed to the oral environment, but the edges of the cyst will be sutured onto the oral mucosa. So that is the way in which you keep the cyst open in marsupialization.
Okay, thank you, ma'am.
Madam, Dr. Nikita Sahu has raised a question: how to differentiate between OOC and epidermoid cyst as both having the similar histological features?
Okay, so only difference is the site of occurrence. Orthokeratinocyst odontogenic cyst occurs inside the bone, whereas the Udari, what is the other lesion?
OOC and the epidermoid cyst.
So the epidermoid cyst generally occurs at a soft tissue location. So that is the main difference. OOC occurs inside the bone, epidermoid cyst occurs at a soft tissue location.
Okay, thank you very much, madam. So we have another question from Dr. Dinesh Shankar. Can we consider the OKC, which is without any syndrome and crossing midline, can be considered as keratocystic odontogenic tumor? Or still we have to consider as cyst as WHO classification 2017?
I think it's better to, even if the lesion cross the midline, it is better to consider it as a cyst as per the guidelines given in the 2017 WHO classification.
Thank you, madam. Madam, Dr. Praveen Naik has raised a question, has told that it's a nice presentation, and his question is, should we consider Golgi syndrome only with multiple OKCs?
Yeah, that's the thing. Sometimes at the initial presentation, you may even see a single lesion. But if you see a OKC at an atypical location or at an atypical age, then still, even if you see a single lesion, you should look for the other features of Golgi syndrome and exclude it.
Thank you, madam.
Thank you. Next question is from Dr. Swati Raman. Ma'am, can you please explain the controversies behind OKC to KCOD and again back to OKC?
Okay.
A very popular question.
Yeah, so in 1992 WHO classification, OKC was considered as a simple cyst. But in the 2005 revision, it was considered as a cystic tumor. 3 reasons were given. One reason was that the lesion showed a very high recurrence rate. The second reason was that the lesion was identified to be associated with the patch gene mutation. And the third reason given was that it is associated with Golgi syndrome. So those were the 3 reasons that were given when they reclassified the OKC as keratocystic odontogenic tumor in 2005. But in 2017, again, they considered the keratocystic odontogenic tumor as a simple cyst. The two reasons that were given were, one, firstly, they said that now the OKCs respond to decompression. If it is a benign tumor with uncontrolled proliferative activity, it should not respond to decompression. That was one reason. And the second reason was the patch gene was identified even in simple cysts like dentigerous cysts. So the presence of patch gene mutation was not a reason to consider the lesion as a benign tumor.
Thank you, madam. Now, to add on to that, if I ask your personal opinion on this, so what's will be your...
OKC is a simple cyst.
Okay.
It should classify or categorize under the developmental cyst category.
Okay, madam. Thank you.
Madam, Dr. Radhika Sharma has raised a question. Why is there a higher recurrence rate in parakeratinized variant?
Okay, the reason is if you look at the epithelium in the parakeratinized variant, you may see suprabasal as well as basal mitosis. So when there are mitoses, that means the lesion or the epithelium can grow on its own. And because of the high proliferative rate, even if you leave a small piece of epithelium behind, it can give rise to a new lesion. Whereas if you consider the orthokeratinized variant, the epithelial lining of the orthokeratinized variant does not show a lot of mitotic figures, so it does not have an intrinsic growth potential. That is why you see a lot of recurrences in the parakeratinized version and no recurrences in the orthokeratinized version.
Thank you, madam.
The next question is from Dr. Tanvi, madam. Radiographically, how can we differentiate KCOT from ameloblastoma?
You can definitely differentiate the two lesions, but there's one clue that you can use, and that is in conventional ameloblastomas, you may see both lingual and buccal bone expansion, whereas in KCOT or the OKC, you don't see both lingual and buccal bone expansion. So the presence of both lingual and buccal bone expansion can be considered as a feature or a clue to identify an ameloblastoma.
Okay. Madam, it is basically clinical and radiological pathological combination, the diagnosis.
Sorry, Sumudu.
It's basically radiological, pathological, and clinical combination in diagnosis. Okay, thank you, ma'am.
Madam, the next question has been raised by Dr. Suadija. This question is with reference to the first poll that we conducted. And the question is, madam, can we explain poll 1 by using the sunlight factor?
There was nothing in relation to sunlight given for the answers. So how can it apply? Right. Okay, I understand. Like when you consider the 50-year-old patient, because the patient is an elderly patient, the patient may develop basal cell carcinoma. I think you are thinking like that. But the thing is, basal cell carcinomas that occur in Bollingall syndrome generally present in areas that are not exposed to direct sunlight. So sunlight would not be a factor here.
Thank you, madam.
We have another question from Dr. Diksha Singh. Ma'am, what are the limitations of gene therapy for treating odontogenic tumors, especially ameloblastoma?
Okay, so one limitation that I can think of is that it is not widely available and the expense. Other than that, I can't think of anything else at the moment.
Thank you, ma'am. I think we have another question from Dr. Dinusha. I think we got the answer in the previous sessions. Udari, can we move on to the next question from our teacher, Professor
Yes,
Artigal?
Professor Manjula Artigal has raised a question, madam. First, he has thanks for the excellent presentation. What evidence is available regarding possible malignant transformation during prolonged dredging?
Sir, I'm sorry. I don't have any evidence, or I did not come across any articles regarding malignant transformation with prolonged dredging.
Okay. Thank you, madam.
Okay. We have a question from Dr. Sri Chintu. How to differentiate intraoral basal cell carcinoma from peripheral amyloblastoma?
Actually, now we think that really there is no entity called intraoral basal cell carcinomas. If you consider the older literature, you may come across some case reports diagnosed as intraoral basal cell carcinomas. These can be actually peripheral ameloblastoma of basal cell subtype. So we really don't have to differentiate intraoral. There's no entity called intraoral basal cell carcinoma.
Okay, Udari.
Dr. Karishma Desai has raised a question. When should dredging ideally be taken as treatment modality?
I think it should be answered by a surgeon. Sumudu, can you help me?
Ma'am?
Sumudu, can you help me to answer this question? When should dredging ideally be taken as a treatment modality?
Yeah, I think the best person to answer this is Professor Manjula Artigal. Now he's with us. I can allow him to share his thoughts, madam. Shall I?
Sure, please.
Yes.
In the meantime, shall I move to the next question, Dr. Sumudu?
Yeah, please.
Yes. Dr. Richa Nangalia has raised this question, madam. Which subtype of amyloblastoma is most common? Is it the follicular or plexiform?
Okay, according to the results that we have from our data, follicular amyloblastoma is more common compared to plexiform amyloblastoma.
Thank you.
But there are studies where they have shown that plexiform amyloblastoma is the commonest variant as well.
Okay. Thank you, madam.
Yeah. Thank you, madam. I think Professor Manjula Artigal, he's with us. Sir, can you?
Yeah, yes.
Yes.
Thanks,
Please.
Primali. Actually, we've been doing dredging for ameloblastomas for more than 6 years, I suppose now. And actually, about, say, 15 to 18 years back, 15 years or so back, we got this information from one of our colleagues in Bangladesh. And at that time, actually, he showed some pictures of 100% resolution of conventional ameloblastomas with dredging. But we were reluctant to do that. But after going through several articles and some evidence, of course, we adopted that. And we are doing routinely now for lesions confined to the bone, actually, especially mandible. I'm a bit careful in doing it in the maxilla because of the reasons you have also mentioned, that it could go into the soft tissue and the nature of the maxilla. So we are doing it routinely for conventional ameloblastomas in the mandible, which doesn't show any soft tissue involvement. And we got actually very good results, but there are resistant cases. And why I raised that question regarding malignant transformation is there is one article saying that prolonged dredging and prolonged giving too much of time rather than 2-3 months. If you delay it for 4-5 months and going on for years, there's some evidence for malignant transformation. During our 6-year period, we have one case questionable whether there is a transformation. We just have to look carefully into that. So that's what my opinion regarding this. Thank you.
Thank you, sir.
Thank you very much, sir. Being his trainee, I have seen him practicing dredging extensively, so I thought he would be the best person to answer this question, madam. Okay, thank you very much, sir. So, can we have the next question, please?
Yes. Dr. Fabina has raised this question. Any indication of decompression and marsupialization? Which one to perform in which type of cyst?
Again, Sumudu, can you help me?
Madam, I think there was an interruption in the connection. Could you please?
Yes. So can you help me to answer this question, Sumudu? Indication of decompression and marsupialization, which one to perform in which type of cyst?
Okay, madam, again, we can have Professor Article to answer this question as, can I have him in the session, madam, please?
Yes, sure.
Yeah. Sir?
Shall I move on to the next question?
Yeah, please, Udari.
Dr. Mukund Nair has raised this question. Can personalized gene therapy be a consideration for treatment of OKC?
Okay, so if you consider the patch gene, there's a particular pathway that can be blocked, and then you can prevent the occurrence of OKC. But it is not the same type of gene therapy that is used for amyloblastoma. It is a different type of gene therapy that can be used based on mainly the gene defect that is observed. I am not very sure whether people have developed this type of gene therapy, but if you consider the pathogenesis, we can sort of like the OKC occurs due to a mutation in the patch gene. So if you can prevent this mutation, then that will be a type of gene therapy that can be used for OKC.
Thank you, madam.
Udari, please continue.
Okay. Dr. Aravinda has raised this question. Thanks for the wonderful presentation, madam. Your opinion on presence of daughter cysts in KOT and its recurrence potential.
Okay, so if you consider the OKCs that occur in Bowling-Cole syndrome, we may see more daughter cysts and satellite cysts in syndromic patients, and there's a high recurrence potential when there are daughter cysts compared to OKCs that do not have daughter cysts.
Okay, thank you, madam. An anonymous attendee has raised this question. Great presentation, madam. Can you please explain the non-syndromic cause of multiple OKC?
Non-syndromic causes of multiple OKC. I'm sorry, I'm not very sure about it.
Madam, could it be due to gene mutations maybe?
Yeah, but like you may see gene mutations even in single OKCs.
again, Dr. Bandhavi has raised this question. Ma'am, can we use targeted gene therapy to OKC also? I think we answered this question, madam, right? Yes. Okay, madam, Dr. Aishwarya raised a question. Her question was the first question. She has mentioned the question again. Ma'am, I wanted to actually ask that which biopsy is used in which kind of lesions, also apart from OKC and ameloblastoma. As in, she's asking the indications.
Right. If you see a patient with a very large multilocular radiolucency, then it is better to take an incisional biopsy. On the other hand, if you see a patient with a small unilocular radiolucency, then you can even go for an excisional biopsy.
Okay, thank you, madam. Another anonymous attendee has asked, is KCOT actually a cyst or a tumor?
I think according to the 2017 WHO classification, now we have to consider it as a cyst, and I agree with that decision.
Okay, madam. Questions which are remaining are related to decompression and marsupialization. Madam, I think the best person would be Professor Artigala to answer those questions. Dr. Sumudu, were you able to get him in touch with us?
Yeah, I think I'm trying to connect him. So he will connect in a minute. So we have another eminent surgeon in the country also with us, Dr. Sunil Karunatilaka. So, madam, can we have him in the discussion, please?
Sure.
Yeah. Sir? Sir? So I'm trying to connect Dr. Karunatilaka. Sir? Sir, can we unmute your mic and... So are you with us? Okay, as we are unable to contact both of our teachers, let me answer this question. The terms decompression and marsupialization are used in many reports, many research articles as synonyms. So decompression implies that creating an orifice in the cyst with the smallest possible opening and placement of a tubing to reduce the pressure. So this maintains the drainage within the cystic lesion. So this means that marsupialization comes under category of decompression. So marsupialization is any method used to relieve intracystic pressure by keeping a relatively larger patent opening to the exterior of the mouth. However, in a surgical sense, marsupialization really means of decompressing a cyst and the conversion of cyst into a pouch of the mouth by suturing the cyst wall to the oral mucosa. So this implies that creation of sizable opening or the communication simply. Finally, marsupialization and decompression are similar surgical procedures aimed at decreasing cystic pressure by reducing the, decreasing the cystic pressure and inducing bony apposition of the cystic wall. So it is most often used in 4 common cystic lesions, including dentigerous cyst, OKC, radicular cyst, and unicystic ameloblastoma. So the treatment selection depends on surgical setup and the personal preference of the surgeon. So therefore, there's no reliable data on what is best for what. So that's the answer.
Madam, there's a question from Dr. Saranya. Single BRAF inhibitor, dual BRAF inhibitors, which is more beneficial in ameloblastoma, madam?
As I said, I think the dual inhibitor is more beneficial.
Madam, Dr. Aravinda has raised a question. Any recommendations for choosing the site of incisional biopsy?
My recommendation is that you should not take a superficial biopsy to include only the oral mucosa. Better to take a deep biopsy.
Thank you, madam. Dr. Aravinda has again raised a question. Do you recommend analyzing soluble protein content of cystic fluid to analyze the type of cyst?
Okay, theoretically we say that if it is a OKC, you may see a soluble protein content of less than 4 grams per deciliter. But actually I don't think that is a very useful thing to do, mainly because by analyzing the soluble protein content, you will not be able to differentiate OKC from an orthokeratinized odontogenic cyst.
Thank you, madam.
So thank you very much, madam. So as time is running up, so we have arrived at a conclusion of this session. And thank you everyone again for staying connected. I hope you had a fruitful session. Let me once again thank Professor Primali Jayasooriya for her contribution to this session. And thank you, Udari, for assisting me today. And this is a kind reminder before we wind up. This webinar will follow up with an email. Please follow the link to submit your feedback for further improvements. Also, please subscribe for our next webinar, changes of using oral epithelial dysplasia in management of OPMD and oral cancer. Thank you very much and have a good night.
Thank you so much.